topic on which I'll be speaking today is residential camps for type 1 diabetes, children and adolescents in India, how we empower particularly the families of these children. I'm attached to Nanavati Max Super Speciality Hospital, and I'm one of the founders of the Juvenile Diabetes Foundation Maharashtra chapter, Mumbai. Now, my story started in 1980, the year in which I cleared my MD, having worked under Dr. Meena Desai, who was the pioneer of pediatric endocrinology in India. Now, in that year, when I cleared my MD, I got a call from Dr. Vijay Ajgaonkar, a leading diabetologist in Mumbai at that time, and he had been one of my teachers in internal medicine during my undergraduate days. I don't know why he remembered me 7 years after that, but when I cleared my MD, I got a call from him and he said, Aspi, I would like you to join me and let us work together to change the lives of children and adolescents with diabetes. So that was the defining moment. I went to him, I accepted the invitation. At that time, the scene in Bombay was quite depressing. There were not too many cases of children and adolescents with diabetes, and there was very little awareness. I'm sure many children would have died even without a diagnosis, having been labeled as acute asthma or acute abdomen or acute encephalitis. There was no doctor trained in management of pediatric diabetes. Patients were on 1 or rarely 2 injections of insulin a day and a restrictive diet. There was nobody to counsel them. They had a social stigma attached to them. They felt isolated. They had no hopes for the future. They felt helpless and hopeless. Naturally, they were poorly controlled. They were stunted. They have had frequent seizures due to hypoglycemia, but were labeled as epileptics very often. Many died of ketoacidosis. They had early microvascular complications, and many were depressed. 2 things were very clear. One, we had to empower the patients. We had to train the patients to manage their own diabetes, because this is one disease in which the patient has to do everything at home, taking their own shots, checking their own blood or urine, planning their diet, planning their activity and everything. This cannot be achieved with a prescription. But more important, we have to address the psychosocial concerns. And therefore, besides Dr. Ajgaonkar, the diabetologist, myself, the fresher pediatrician, we also included a psychiatrist, Dr. Anand Nadkarni, and a few years later, Dr. Manoj Bhatavdekar. And I would say that they are very, very, very important members of our team. And I feel a mental health specialist must be a member of any team that cares for children and adolescents with diabetes. Educators were required to train the patients, and we felt, and we still feel, that senior patients and parents of well-controlled diabetics can serve as the best educators as well as social workers. 5 reasons. 1, they can relate to the patient's problems. They have gone through it themselves, or rather they are going through it themselves. They can empathize with the patient, and they have better acceptance amongst the patients. It's a different thing for me to tell a patient, take your shots regularly. It's a different thing when they hear it from somebody who's doing it himself. They can speak with authority and practical knowledge. They are best suited to help newcomers in the initial turbulent phase after diagnosis. And they can serve as positive role models. So, for all these reasons, and with all this in mind, we started a support group, the Juvenile Diabetes Foundation Maharashtra chapter, and we said that we would cater to all categories and all age groups. So what happens? The rich can finance or adopt the poor. The intelligent can guide the not so intelligent. The influential can help the less fortunate with school admissions, jobs, and so on. And the adults in the group, the seniors who have grown up, can guide, can inspire and serve as role models, or those who have not controlled themselves so well can serve as a subtle warning for the new entrants. And since there was a pediatrician and Dr. Ajgaonkar had given me full authority, all the scientific management below 18 years would be in my hands, and there was an adult diabetologist, there was continuity of care assured beyond adolescence. So we started with a weekly comprehensive care clinic for not just children and adolescents, but all those with childhood onset diabetes. We added on monthly theme-based meetings, but then we found that the time was too short to cover everything, education, psychosocial aspects. So then we thought of holding or conducting residential camps where we could have a lot of time and a relaxed atmosphere and supplemented with mini one-day camps. Abroad, there are residential camps. They have been there since a very long time. But the aim there is to provide a safe environment to participate in challenging physical activities under guidance and supervision. Our aim here was different. Our aim here was children with diabetes, their parents and the entire medical team will stay together as a family for 3 to 4 days. And we'll have group education, group discussion, discuss threadbare all the psychosocial issues in a relaxed atmosphere. And with this in mind, the first camp in India we conducted in December 1983 in Khandala, a holiday resort near Mumbai, with 11 patients. And where was this conducted? In one of the patients' bungalows. And you know, that patient herself didn't attend the camp. She didn't want to meet others with diabetes. Today, she's a practicing endocrinologist in Australia. The first 2 camps were held in her bungalow, the third camp in another patient's bungalow in Dahanu, and thereafter the numbers went on growing and we could not conduct the camps in patients' bungalows. So then we started looking for campsites and we have been very, very fortunate. There were 10 criteria for picking a campsite. 1, it should be a holiday resort, so there's a nice relaxed atmosphere. It should be easily accessible by road. We transport all our patients from Mumbai by buses to the venue to save time. The entire premises should be booked so that there are no prying eyes or awkward questions asked by others. There should be sufficient bathrooms, adequate water supply so that the day's proceedings are not held up. We can start on time. There should be 3 or 4 or more halls or makeshift halls, even open air spaces where we can conduct educational activities for big groups and small groups. There should be facility for cooking food to our choice, suitable for the campers. All this should come at a reasonable cost. And of course, since there are so many children, there should be sufficient play areas. All this we managed to get. But the premises should be able to accommodate everyone and it should be available year after year. And this is where we faced problems initially. So we started with the St. Xavier's Villa, a wonderful place, and we conducted a camp in the winter Christmas vacation. But after several years, they said, sorry, we can't give you the premises during Christmas. We need it for our own people. So we had to move on. So we moved on to another villa in the same area, Tulsi, Sadhana, Kutir, which was usually being rented out for meditation, yoga, etc. And we had a camp here for many years, but we could not accommodate the large number of people who were attending the camps. This place could only accommodate about 100. So we had to book holiday homes, a sanatorium, some apartments on hire near the camp area and have a minibus to transport the patients to and fro. Now this became inconvenient and we could not really spend many hours in the late evening together. So then, by the way, in this picture, you can see me, you can also see Dr. Manoj Bhatavdekar, who's our psychiatrist, and you can see 3 parents. The one on my left is Mr. Vipul Mehta, who's the administrator currently. His daughter, who's a juvenile diabetic, is now a diabetologist and she runs the clinic at the JDF. The other 2 are also parents of children, and the man on my extreme right is the caterer who's been with us for all these years at St. Xavier's Villa at Sadhana Kutir, and he's the one who then found for us the premises we currently go to, Shanti Sadan, a little beyond Ronalda. Now this is a wonderful place. You know, we have a lot of accommodation, as you can see in that image, rooms where families can be put up. And in the building opposite that, we have huge dormitories where adolescents, young adults who have come for the camp alone can stay. And we have a large number of halls for educational activities. There's a wonderful view. There's a small hillock where we can go for a trek early morning on the days of the camp. A lot of play area, which is important for the children. We conduct the camps during winter. Why did we select winter? Number one, the weather is pleasant. Number two, there's less chances of water shortage. And number three, the winter vacation is short. So during the long summer vacations, many families prefer to go on long vacations, go to the native place. They are more likely to attend or would prefer the shorter winter vacation. As far as funding is concerned, these camps are conducted on a no profit, no loss basis. The expenses we incur are on bus travel, stay, private room or dormitory, and food. As far as education is concerned, as far as counseling is concerned, it's always been at no cost. No member of our team has ever charged a single paisa for conducting the camp. The entire medical team offers voluntary service. So currently, the last camp we had, the patients paid something between 2,500 to 3,000 per head for the entire 3 days, all inclusive. No patient is kept away because they cannot afford. Those who cannot afford are also most welcome. Now, who attends the camps? The children, adolescents with type 1 diabetes, the young adults with pediatric onset diabetes, parents of children, and in selected cases, we take along siblings and grandparents who need to be counseled. The number of patients, and I'm referring to children, has varied from 11 in the first camp to more than 80 up to 100 in subsequent camps. And the staff includes our whole medical team, including clinical psychologists, play therapists, educators, and social workers. Now the program in brief. Pre-breakfast, there's either meditation, on one day Zumba or a morning jog. Before every meal, patients take their insulin and check their blood sugar under supervision. Between breakfast and lunch, we have a common session on the first day, introductory session. Second day, a session on nutrition and meal planning. Third day, a quiz and brainstorming session. Between lunch and dinner, we divide the patients into small groups and have sessions on diabetes education and counseling. And post-dinner, we have an entertainment program. So coming to the first day, first session, post-breakfast, the introductory session, a very important session where patients introduce themselves to each other with a focus on positive achievements and on what they regret having not done or having done, which they should not have done. Now, this is very, very, very important for everybody. And then we have introduction to type 1 diabetes. We address the myths, the fears, we instill self-confidence and genuine hopes. Remember, no education can succeed or can penetrate a mind that is filled with all these negative thoughts. So the mind has to be first emptied of these negative thoughts, as our psychiatrists would say, before we can begin education. So there are 10 points we stress on. One, and which the patients obviously see when they attend the camp, I'm not the only one. Two, there is no need to feel guilty because there's nothing you did or you didn't do that caused diabetes. It would have happened, it had to happen, it's an accident of nature. There's no need to feel guilty about pricking the child so often. You cannot feel guilty about doing something which gives life to your child. There is no alternative to insulin. And this patients hear from others who have tried alternatives with disastrous results. Your finances will be taken care of. Don't worry about that. Your child can continue doing everything that he was doing before he got diabetes and could have done later on had he not got diabetes. Many people don't realize this. We have to open their eyes. There's nothing your child was doing which he has to stop doing. Most important, diabetes is not your identity. You are an individual. You have your identity. Diabetes is by the way. Number 8, insulin keeps you alive. It cannot keep you healthy. To stay healthy, you need much more than insulin. You need diet control, you need monitoring, you need planned activity. A cure is not currently available. Anybody who offers you a cure today is cheating you. A cure will come, but you have to stay healthy to benefit from it when it comes. And that is why focus on now, not on the future cure, which will come. And your future can be bright, provided. So all patients are worried about the education, career, marriage, childbearing, long-term complications, lifespan. So we address all of these in a very positive way, but giving the correct picture, underlining the association of a bright future with consistent good control. And that's how we try to enlist their cooperation for regular follow-up and screening. And then to complete this brainwashing and prepare them for the subsequent education, there are 3 points we highlight. One, your priority is the child should lead a normal childhood. So we encourage parents to avoid diabetes-centered conversation. When your child comes back from school, don't ask about his diabetes, ask about what fun he had. And we stop the blame game. If there's anything that's going wrong, it's not the fault of the child, it's nobody's fault. We have to analyze why it went wrong, correct it. Number 2, perfection is impossible. Near perfection is desirable. You have to have practical goals. Many parents are depressed when they find that the sugars are haywire. We tell them that you can't have perfection. Don't expect perfection. Don't get depressed. Instead, think what you can do to improve things. And lastly, a child with diabetes has to eat healthy, lead a healthy lifestyle. But who says that only the child has to do it? The entire family has to do it. And the entire family will benefit by doing what the child will now be doing, which every one of us should ideally be doing. Now, having completed the brainwashing, we disperse for lunch. And then before each meal during the camp, not only the first day lunch, patients take their insulin under supervision, and we teach them to look for lipo hypertrophy. Remember, all our treatment modifications are based on the assumption that the patient is taking the right amount of insulin correctly and that the self-monitored blood glucose that the patient is reporting are accurate. If these are not, then our treatment is of no use. So therefore, we make patients take the insulin under supervision. They learn from their mistakes, and those who are waiting to take their insulin in the queue also can learn from others' mistakes. This is the girl who's supervising the insulin. She's the one I told you, who's now an endocrinologist in Australia. Post-lunch, between lunch and dinner, the sessions on day 1 and day 2. For these sessions, patients are divided into 4 small groups. 1, parents of below 6. Number 2, parents of above 6. Number 3, adolescents. Number 4, young adults. And children go with the play therapist. And for each of these groups, we cover 4 topics by rotation: decision making, emergencies, that is hypo, emergencies, that is sick day management and prevention of DKA, and coping with diabetes. And then we have 2 special groups: those who need very basic education, we know they will not cope with anything more advanced, and the higher level, the pumpers. What is the format of the medical sessions? There's a brief focused presentation, followed by case studies in real life situations. The policy we follow is teach only what the patient can apply. Don't try to teach too much, because that dilutes the focus and they remember nothing. Whatever we teach, we give printed material and encourage patients to make notes in their own language. Now, any statement on what you do will be coupled with a discussion on why many a times you don't do it. So what are the barriers to implementation? And for this, all the sessions are attended by one or the other clinical psychologists. And patients share practical tips learned from others' experiences. Very briefly, the 4 sessions, in 1 slide each, I will tell you what we must teach. For decision making, we teach patients how to keep their records, incorporating 1, when do you check the sugar? 2, what is the blood glucose target for that time? 3, which insulin controls that sugar? And 4, a comments column. Was anything other than insulin responsible for an abnormal value? For those who use basic carb exchanges, we teach pattern adjustments and insulin sensitivity factor. For those who have learned advanced carb counting, we teach the concept of insulin carbohydrate ratio and insulin sensitivity factor. Many patients are afraid or reluctant to act on the results. So we promise them that after the camp, we will hold their hands. We will give them support on email, WhatsApp, SMS to apply this information in day-to-day practice. Coming to hypoglycemia, we teach 10 things. 1, hypoglycemia means sugar below 70. So if you have symptoms of hypoglycemia, but your sugar is above 70, do not treat as hypoglycemia. We classify the hypoglycemia as mild, where the child is alert, knows what's happening, moderate, where the child is disoriented, and severe, where he's unconscious or convulsion. The first aid we tell them is powdered sugar or glucose. And after that, do not give anything. I mean, I'm stressing this because these are the common mistakes. And when we teach too much, they forget the basic issue. So give sugar and then wait for 15 minutes. Do not give anything in those 15 minutes. Then recheck the sugar. And if required, give more sugar. And only when they're out of it, give a snack to eat. When to give glucagon, how to give glucagon. If you are rushed to the hospital, unconscious or convulsing, the amount of D10 or D25 has to be given. We ask them to write it down because sometimes in small nursing homes, the doctor may not know and they may overtreat. The importance of keeping sugar on your person, the importance of carrying an ID card, the importance of not maintaining secrecy. So if this happens, hypo happens in a place outside the home, there is somebody who knows how to help you. Prevention, and if recurrent hypos are there, you should report to the doctor for investigation for other comorbidities. And regarding emergencies, DKA prevention, we tell the patients never stop insulin when you are sick, even though you're not eating. For insulin dose, don't follow your appetite, follow your ketones and blood sugar. Blood sugar 90 to 180, take your usual dose. Above 180, take your usual dose, and 10 or 20% of total daily dose extra based on ketones. If it's below 90, delay the bolus, don't stop it till you eat. If you're not hungry, take sweet liquids with sugar below 180, salty liquids with sugar above 180. When you go to hospital, and if you go to hospital, carry a little note from us. The only thing to be given in the first hour is normal saline, no insulin, no bicarb, no potassium. And lastly, the fourth session, coping with the social stigma. Type 1 diabetes is not a visible handicap. Nobody can look at the patient and say this patient has a problem. But it is important to reveal for better compliance and for emergency help, as I just discussed. For better compliance means, so you can take your insulin outside the house if you have to. You don't have to miss it because you don't want people to know. But then you have to reveal only to relevant people. And how do you reveal? As a matter of fact. You don't have to be meek. You don't have to be apologetic. It's not a crime to have diabetes. And stress, parents are told that when they reveal, they have to stress on how well the child manages his condition. So you praise the child for doing a great job rather than being sorry or appearing sorry that he has diabetes. Patients are encouraged to strive to excel in some field. Type 1 diabetes should not be the identity. The identity should be some achievement. And we have seen, and patients attending the camp see, that those who have done well in studies, well in their careers, have found good partners in life, and they are respected in their field, they are respected in their community. Secrecy before marriage, never. If somebody is not ready to marry you because you're a diabetic, it's not worth marrying that person. Obtaining a job may be difficult, but retaining it is easier because you learned to lead a disciplined life. And the coping session, besides covering these aspects, is predominantly a question and answer session. And while all this is going on, the children are with the play therapists, playing and being taught some basic aspects about diabetes care. On the second morning, the common session is on medical nutritional therapy, where we tell the patients that diabetes diet is nothing but return to healthy cooking and eating, which all of us should be doing, but unfortunately do not do. Children with diabetes are more prone to organ damage with faulty eating. We who do not have diabetes are also prone to organ damage without eating, but in ours it takes a little time. So there's no diabetes diet. So what's extra? What's special? Special is meal planning. You have to learn to match your insulin with your carbs. And for this, most of our patients use carb exchanges with a little bit of carb counting. Very few use advanced carb counting alone. What are the barriers to good nutrition? This has to be discussed with the family, and if the grandparents are there, with the grandparents. How to modify the typical Indian diet, which is high in carbs with high glycemic index, low in protein, unhealthy fat. Food should never be an expression of love. And many grandparents and parents think that obese children are healthy, obese children are unhealthy. The elders' approach to junk food needs to be corrected. Junk food should not be kept in the house or glorified in any way. There's a no breakfast culture, I feel, in India, in Indian households. children are mimics. Parents cannot tell the kid, look, have your breakfast when they don't have it. Children don't do what the parents tell them to do. They do what they see the parents doing. Insistence on having milk as a drink. I mean, children need dairy products. They don't need to just drink the milk. This is something which unfortunately many Indian parents do not seem to understand. And the joint family system can be a big hindrance because lifestyle alteration may not be acceptable to everybody. This is a problem we have to discuss. In school and college, the problems are odd timings. Many a times children have to get up and rush to school very early. Sorry, there's no time for breakfast, or they go to school late morning. So there's a very short interval between breakfast and lunch if they wish to have lunch in school. So we have to come up with innovative insulin regimes. There are very short breaks. So it's very nice to tell them take insulin in school, but then the time to take the insulin and to eat is so short, and the child may not want to get up before the class ends for the break and take insulin. Unhealthy school meals, sometimes made compulsory by some schools, tiffin sharing with the child, birthday parties, uncooperative school managements, and of course, when they come home, bigger kids, adolescents, coaching classes and extracurricular activities. How to manage all this and yet stick to healthy eating and matching insulin and meals is something that we need to discuss. Post dinner, we have the entertainment program. That's me as Santa Claus over there. On the first day, it's pure entertainment where children show off their talents. And let me tell you, each and every child, I'm shocked, I'm surprised, but each and every child is very, very talented. I mean, the way they sing, they dance, they recite poems, it's amazing, you know. And on the second day, we have entertainment with a message where there's kids plays on themes such as sick day, hypoglycemia, and so on. So here children are freaking out. In the new place that we have gone to, not new anymore, of course, the latest place I should say, we have a nice area where in the night we have a J Fest. And you can see children having a great time. And we also were coaxed by them to have a ramp walk in ethnic wear. This is the Zumba session before breakfast. On the final day, we have a quiz contest to assess and reinforce education. Patients are divided into 4 groups: mothers, fathers, boys, and girls. And there's a leader for each group. We present a case scenario. The leader presents the answer after discussing with the team members. If it is incorrect or incomplete, the next team can add on to it and so on. And then the answers are discussed. And the final session is brainstorming. What the group can do for their children. Create awareness, remove misconceptions in society, communicate with school and college authorities, raise funds for the poor patients, adopt a child, strive for better deals with the pharmaceutical companies, serve as educators, help in administration, help in finding suitable employment when these children grow up, help with marriage assistance, marriage counseling, and conduct camps in their hometowns. And I'm so happy to say that at least 2 groups, Nagpur and Bhavnagar, after attending our camps, started conducting their own camps. I've attended the camps and I must say they are wonderful. Some of our old patients drop in just for the introductory session or for the last day to say hello. Here you can see me with my first diabetic patient in my private practice, Praveen, with his family, his wife, his children, his parents. And here is Dr. Ajgaonkar's first patient, Meena Fernandez, who's still alive. She's in her 70s now, right? And the camp ends with the camp anthem. This is our psychiatrist, Dr. Manoj Bhatawdekar. He's a great singer too, singing the camp anthem, Hum Honge Kamyab Ek Din, and the parting shot. So what the camp achieves, a favorite slide which I made in 1983, it's only modified now, cyclic AMP, the emotionally disturbed and confused patient is hopefully converted to an emotionally adjusted and confident patient. Unfortunately, we have not been able to do too much research at the camps, but one of my DNB students had collected data in the 2014 and 2015 camp for 57 pediatric age patients from Bombay who attended the camp. The HbA1c at the 2014 camp, the mean value was 9.1. 3 months later, it was 8.8. And in the December camp, it was 8.7. and 3 months later, 8.4. And when we took up 20 patients from the group who had attended both the consecutive camps, what we found is that the mean HbA1c for those 20 patients at the beginning of the first camp was 8.7. 3 months later, it fell down to 8.1. At the beginning of the next camp, it had gone up marginally to 8.3. And 3 months after that, it had come down to 7.9. So moral, you need to recharge your batteries. The number of patients who had HbA1c below 7.5 was 2 at the beginning of the first camp and was almost 50% of the group at the end of the second camp. Beyond the winter camp, we have sports events, we have treks, we have hikes, so that children can learn to do everything that any other child would do, any other adolescent or young adult would do in spite of the diabetes and do it properly. Now, this is one of my patients. He's now in his early 30s, and I saw him when he was 9 years old. He went cycling to Khardungla top with 12 other people, of whom 11 were military recruits. And only he and one military recruit reached the top. This is the highest motorable route. And then he did the triathlon in Dubai, swimming 1.5 kilometers, cycling 40 kilometers, and running 10 kilometers back to back. And when I asked him, why do you do it? He says, because I want to prove that I can do anything that anybody else can do and maybe much more. Dr. Manoj Bhatavdekar here. Dr. Deepak Dalal, who is also an adult physician. So we have continuity of care. When the patient crosses 18, he takes over for the medical management. And Mr. Vipul Mehta, I spoke to you about him earlier. And this is our Gen Next. This is Dr. Ajgaonkar with Dr. Anushri. She's a diabetologist. And Dr. Sachindra, he's a homeopathic doctor, but he's on the insulin pump. He's had diabetes since the age of 11 years. He's a leading homeopathic practitioner. He's almost 50, mind you. And his control is so good on the insulin pump, you think he's a non-diabetic. And he does everything. Thank you.